Good morning, everybody. So we're in the part 3 of what's probably going to be a 4-part series on heart disease and statins. Hey, Crystal. Hey, Eileen. So to review, we talked the last 2 classes, about the science of cholesterol and what it does and why it's important and why it's not bad. And then we also discussed the U.S. food pyramid and the history, which was based on faulty science. And then we also talked about the research on statins, which is probably academically dishonest. So there's a lot of studies on statins, 3,000 of them, many of which have been reviewed since 2005 and found to have exclusionary parts of their data. So stuff that didn't support the use of statins for prevention of heart disease and reduction in mortality and side effects were just eliminated. They weren't reported. So if you're going to have a hypothesis and write a scientific paper, you just, if it doesn't fit your hypothesis, it doesn't fit, and that's as important as something that does fit. So we need to know what doesn't work as much as we need to know what does work, right? Okay, so I left you Friday with a little teaser about diabetes and statins. Okay, and so the FDA has made statin manufacturers put a disclaimer or warning on their labels about side effects, one of which is dementia. Hey, Linda. Hey, Christy. And one of which is raising your hemoglobin A1C and basically raising your blood sugar levels. So I talked about Friday, I said, okay, sugar intolerance, weight gain, insulin resistance, metabolic syndrome, type 2 diabetes. And if you don't know what those are, it would kind of behoove you to know that because we're in the middle of an epidemic of sugar intolerance or insulin resistance, hey Wendy, and metabolic syndrome and type 2 diabetes. So the common denominator for all of those, so sugar intolerance, weight gain, insulin resistance, metabolic syndrome, type 2 diabetes, is sugar. Okay, in 2015, I went to a meeting in Florida on age management, and I was amongst a bunch of doctors, and I finally went to a medical meeting where I was among a bunch of physicians and nurses and health professionals that thought like I did. So I felt very comfortable. The leader of this group, or the guy that put together the meeting, gave a talk on sugar, and he spent 1 hour and put up studies, et cetera, et cetera. He spent 1 hour talking about the fact that sugar is addictive and it's as dangerous as heroin addiction, and it's a lethal substance. Okay, and we are sugarholics in the United States, probably elsewhere as well. So I'll pick on the US, but we all like sugar. And I always tell people, well, I'm not saying you can't ever have a piece of cake or pie or whatever and never have sugar, but sugar is just a main part of the diet, and it's a carbohydrate. And we've talked about the dietary recommendations from the U.S. food pyramid. So elevated sugar and carbohydrates was basically the first food pyramid. Get your calories from carbohydrates and get your energy from sugar, which it does. But too much of it will eventually lead to type 2 diabetes. So when I was in medical school, I was taught that type 2 diabetes was inevitable if you live long enough. It has been considered, and still is considered, a chronic disease that requires drugs and medical management for your life, and a patient would never be cured of type 2 diabetes. Well, I'm here to tell you that they're wrong, because I've done it. I've done it for too many patients. I've reversed metabolic syndrome in me, and I'll tell you that at the end of this one. So I've gotten a lot of diabetics off their meds over the last 20, 25 years, including those that were on injectable insulin. So even though they're type 2 diabetics, you can become insulin dependent like a type 1 diabetic. And type 1 diabetes is irreversible. It's a genetic problem. They're working on that. I told you last week about 3D printing. They're trying to come up with a 3D printed pancreas that they think might actually cure type 1 diabetes. And I am the first to say that I know very little about 3D printing. I don't get it, but it's being used in medical research. Okay, so diabetes is comparable to coronary artery disease for the risk of death. So heart disease is the leading cause of death in the US. And then the complications of diabetes, one of which is heart disease, comes in seventh. So complications of diabetes is the seventh leading cause of death in the US. Okay, so if you get diagnosed as a diabetic, that dramatically increases the risk of cardiovascular problems, including coronary artery disease, peripheral vascular disease, heart attacks, and strokes. However, here's the kicker. Most diabetics have normal cholesterol levels. Okay, so I'll give you an example. I did a consult on a woman recently, a health coaching consult recently, concerned about her weight of 307 pounds. She's in her mid-30s. She is not diabetic. She does have a little insulin resistance and metabolic syndrome, but her hemoglobin A1C is under 6.5, which is basically the diagnosis of type 2 diabetes. Her total cholesterol is 187. Remember, the American Heart Association says less than 200, so she fits that. Her triglyceride levels are normal. And then her LDL cholesterol, remember the little cholesterol taxi, is 117. The American Heart Association at one time wanted you under 150. Now they're saying under 100. So she's a little high on that based on those criteria. But she's had a 110-pound weight gain over the past 2 years. Since I consulted with her, I think in November, she is down about 50 pounds doing some of the things I'm going to tell you about later this morning. But you would think, based on her 110-pound weight gain, she would have a horrifyingly bad lipid panel, and it's basically normal. She's in the recommended guidelines except for a little elevation of LDL. Her kryptonite is really ice cream. That's what gets her. She can't stay away from ice cream. So we work on some other things for her so that she can have her ice cream-ish, just not as much as she usually has done. So clearly there's something other than cholesterol at work causing diabetics to have a higher risk of cardiovascular disease. Okay, so other studies indicate that those who drink sugary drinks, and I'm talking about high fructose corn syrup, which is just terrible, terrible, terrible for your health, they have a higher risk, much higher risk of coronary heart disease. And then how about dietary interventions that recommend low-fat diets to reduce LDL cholesterol? Well, somebody did a study. So it's called the Accelerate, ACCELERATE, Accelerate study, based on the hypothesis that lowering cholesterol levels prevents heart disease. Hey, Steph. Okay. So there's their hypothesis. And they did this right. So they found out it wasn't working, so they quit doing it. It was a 30-month prospective, you've heard that in the news, prospective, randomized, blah, blah. Hey, Lee. 30-month prospective study of 12,092 participants randomized to a placebo, so randomized, double-blind, placebo-controlled prospective study. Or they were on a placebo or a drug that was used to inhibit cholesterol transfer and lower cholesterol levels. Okay, the inclusion criteria, interestingly, included acute coronary syndrome, which means angina or chest pain from coronary artery disease, within 30 to 365 days. So any chest pain, angina related within the past year, but over a month ago. And then diabetes with coronary artery disease. So these are of the 12,000, they had one of these inclusion criteria. So diabetes with coronary artery disease, peripheral vascular disease, cerebrovascular disease, and statin use for at least 30 days. So they had to have been on a statin for at least a month. Okay, in other words, these were people that were at high risk for vessel disease and heart attacks, according to the American Heart Association. The result, the trial was terminated due to futility. So despite a 130% increase in HDL cholesterol levels and a 37% decrease in LDL cholesterol levels, there was no difference in heart disease rates between those that received the drug and those that took the placebo. So they stopped it and they reported it. That's academically honest. They were working on a drug that they thought would improve health outcomes, and it didn't. They reported that it didn't. Fair. Okay, how about the hypothesis that obesity and eating too many calories is the contributor to heart disease? Well, over 2 billion people in the world are considered overweight, 600 million of which meet the criteria for obesity, which is a body mass index, so kilograms per square meter of body surface area, of 30 or greater. That's the definition of obesity from the New York Life Insurance tables. Okay. So in the United States, 30 million people have diabetes, and then 100 million have insulin resistance. So that's actually included in the type 2 diabetics because they have insulin resistance, right? So 100 million people out of 330 million people, 1 out of 3 almost, have an insulin resistance problem, okay? So obesity and diabetes correlate with each other, okay? But one does not always exist without the other, or with the other, sorry. There are countries like Iceland and Mongolia and Micronesia with significant obese populations that have no diabetes or little lower diabetic risks. And then other countries have less obesity and higher diabetes rates, including India, Pakistan, and China. So it's apparent that eating too much and weighing too much is not the culprit for heart disease. So what's the metabolic syndrome? I keep bringing that up. So there's type 2 diabetes that has its own diagnostic criteria. The metabolic syndrome is a subgroup of insulin-resistant people who are at high risk for developing heart disease as well as type 2 diabetes. So if you don't reverse your metabolic syndrome, you're probably going to get type 2 diabetes and potentially wind up on meds, if not insulin. So the 4 central features of metabolic syndrome are insulin resistance, a given, visceral obesity, so central obesity basically, and body fat around organs. I mean, metabolic syndrome people have they have big tummies and all that, and they also have body fat around their organs. Hey, Joni, Kristen, okay, and then, so I said 4 criteria. So insulin resistance, visceral obesity, plaque-forming lipids, okay, so lipid elevations or cholesterol elevations, and then dysfunction of arterial blood vessel walls. So the diagnosis is the presence of any 3 of these following criteria. So a waist circumference of greater than 40 inches in men and greater than 35 inches in women. Okay, so 3 out of 4. In women, fasting glucose greater than 100 milligrams per deciliter, or a requirement for glucose control medications, and then a triglyceride level of greater than 150, or a requirement for lipid lowering medications. HDL, what's known as the good cholesterol, HDL cholesterol levels less than 40 in men or less than 50 in women, and then a blood pressure greater than 130/85, or a requirement for blood pressure controlling medications. Okay, so it has to do with weight, triglycerides, sugar, and blood pressure. If you hit 3 of those, you have metabolic syndrome. The biochemical marker is a hemoglobin A1C level of 5.7 to 6.4. So the idea is to keep people's hemoglobin A1C less than 5.7. Okay, so the most important criteria of those is insulin resistance, because without it, there is no metabolic syndrome. So why is that? Well, insulin resistance leads to the other criteria. Okay, so here's how it works. Eating a meal increases blood sugar levels, and the pancreas responds by producing and releasing insulin, which leads to an increased uptake of glucose from the blood and reduces glycogen, which is the stored form of glucose. Glycogen is made and stored in the liver with a net effect of reducing circulating sugar levels. And this leads to increasing glucose conversion to its storage form of glycogen and fat. So insulin resistance causes fat cells, the liver, and skeletal muscle to stop responding appropriately, resulting in higher circulating sugar levels. And high blood glucose levels cause chronic inflammation. And you've heard me say it who knows how many times. Chronic inflammation is the basis of most chronic disease. How's that? Well, it causes oxidative stress. We talk about that with the COVID response and oxygen-free radical and reactive species and damage to cell walls. Okay. Insulin resistance and visceral obesity lead to plaque-forming lipids and cholesterol elevation. Inflammatory changes relate to the dysfunction of the lining cells of arteries. Okay. So the endothelium of the lining cells of the arteries are protective and biologically active. Okay, and they respond to normal and abnormal processes in the body. So if you disrupt their normal function, that leads to arterial wall damage. And I told you about the cardiovascular surgeon that said vessels that are damaged by oxidative stress look like somebody took a wire brush to their inner lining. Okay, and that is what allows plaque formation because the vessel wall becomes sticky. Without a sticky and damaged, stress-related vessel wall, cholesterol just passes through an artery. So the pathophysiology, if you want to know that, take my physiology class at State Fair Community College. It's online this summer. So the pathophysiology is detailed, but the basics relate to nitric oxide. So the nitric oxide heals vessel walls and causes vessels to dilate. So it's a vasodilator that's made in the endothelial cell itself. Okay, okay. So hey, Carol, you're gonna like this part. Dr. Jason Fung, who just jumped on here, told me about a few years ago. He's a Canadian renal physician, kidney specialist, nephrologist. He describes diabetes as, quote, rotting from the inside out, unquote. And he was practicing internal medicine and nephrology and was frustrated by the fact that all he had available to him for treating diabetes was meds. And nobody ever got better. So you just take meds and blah, you control your blood sugar, but nobody, they wouldn't lose, people wouldn't lose weight from that. And he thought, well, I'm just going to study this. So he spent years studying sugar and its effects on the body. So he has a article that's called, you can look it up, Jason Fung. It's called Type 2 Diabetes, Reversal, the Quick Start Guide. Hey, Stacy. So Type 2 Diabetes Reversal, the Quick Start Guide. Okay, and explains the dangers of sugar probably better than anything I've ever read. Okay, diabetes leads to heart disease, kidney disease, peripheral vascular disease, blindness, amputations, and premature death. We talked about that last week. So earlier we discussed that statins increase blood sugar levels and hemoglobin A1C levels. That is why the FDA has that on the label. Hey, Dr. Brooks. Hey, Roger. So statin use has insulin resistance as a side effect. Hey, Jeff. Okay, so that potential side effect is now required on the labeling. And the mechanism that causes this effect of statins altering insulin action through the immune system was uncovered by researchers at McMaster University. They also found they increased pro-inflammatory cytokine levels. We talk about the cytokine storm with COVID. Okay, so that gives you an idea of that oxidative stress that elevating blood sugar and hemoglobin A1C levels do. So that team, it's a biochemistry team, continues to study the inflammatory risks of diabetes. So if you watch your caloric intake and lose weight, shouldn't you reduce your heart disease risk, right? That makes sense. Turns out that's not true. About 80% of people, of obese people, have components of metabolic syndrome. Okay, so that makes sense. But 20% of even morbidly obese people do not have insulin resistance. Okay, they're healthy, they have normal lifespans. Up to 40% of normal weighted people have metabolic syndrome with high blood pressure, fatty liver disease, elevated lipids, and cardiovascular disease. Just normal weight. So there's plenty of normal weighted people running around with type 2 diabetes. Hey, Jeff. Okay, there's also a syndrome called lipodystrophy, from which people who have little body fat, they have too little body fat rather than too much. It's genetic, or it can be genetic, or it can occur with autoimmune disease. Okay, it can also occur with paniculitis, which is inflammation of the subcutaneous fat, specifically in the tummy area. Okay, and it can also happen with HIV infection. And those people, so lipodystrophics, have the highest rates of cardiovascular disease and type 2 diabetes. But they're not getting those diseases from eating too much or being obese. Their body fat has nothing to do with it. So it turns out it's not the number of calories you eat that reduces insulin resistance, it's what type of calories you eat that reduces that problem and reduces heart disease. So basically, simply put, eat real food, don't eat or drink sugar, quit counting calories, and move. So physical activity. In addition, Dr. Fung incorporates intermittent fasting, and he thinks that intermittent fasting is what he thinks is the key to sustained weight loss and maintenance of weight loss once you've done it. So that improves your energy, you have less fatigue, and your weight just drops off. I did it this summer. I lost 22 pounds in 2 months just eating one meal a day. Okay. The focus needs to change from the amount of calories to the sources of calories. So the conventional wisdom of the past 40 years incorporates the idea that calories high on natural fat are bad. That turns out to be not correct. And as discussed, lowering LDL cholesterol by reducing calories and low-fat food actually worsens the rates of death from heart disease. Sounds counterintuitive, but I read all the studies. Not all of them, but most of them. Okay. Insulin resistance promotes the development of metabolic syndrome, which can develop by eating low-fat and high carbohydrate calories. Okay, so insulin resistance is from high carbohydrate diets, which is exactly what's on the food pyramid. So even the ratio of fats that we've been eating has changed over the years. So this was pretty interesting when I researched this. In society today, we're eating a lot of omega-6 fatty acids. And in the years past, we ate more omega-3 fatty acids. Both are polyunsaturated fats, and both are essential to our diet, or essential fatty acids, since your body cannot make them. You have to eat them. Okay? They're both structurally involved in cell membranes, okay? But they also serve functions such as regulating gene expression, vision, nervous system health, inflammation, and blood clotting. So in the pre-industrial era in this country, the consumption of these fatty acids approximated a ratio of omega-6 to omega-3 from 4:1 to 1:4, traditionally close to 1:1. So every omega-6 fatty acid you ate, you were also eating an omega-3 fatty acid. So in a typical Western diet today, the consumption has climbed from an omega-6 to omega-3 ratio from 16:1 to 20:1. So 4 to 5 times more omega-6 than omega-3. Soybean oil is probably the largest source of omega-6 in the processed foods we eat. And the problem is that omega-6 fatty acids promote chronic inflammation, again, the basis of chronic disease. So body fat storage of omega-6 has increased 200% in the last 50 years. So stored in your body. Increased amounts of omega-6 in cell membranes has been associated by research with the development of heart disease. Okay, so there's no studies that show the effects of omega-6 on heart disease per se, but there are plenty of studies showing that omega-3 fatty acids are beneficial to heart function and mental health disorders like depression and bipolar disorder. And many of the vegetable oils that we use for processing and cooking food have significant amounts of omega-6 in them. So how do you get omega-3? Well, that's the animal food. Consumption of animal food has dropped dramatically because of that food pyramid. And even in carnivores, the meat from grain feeding is high in omega-6. So the reason you see meats, and of course we're all looking for grass-fed beef or just meat in general, from grass-fed animals is that meat is rich in omega-3 due to the grass feeding versus grain-fed beef, which is high in omega-6. So in a grain-fed diet, okay? So oils that are low in omega-6 and rich in omega-3 are olive oil, coconut, butter, lard, and palm oil, okay? Sunflower, corn oil, soybean, and cottonseed oils contain the most omega-6 fatty acids. And an easy way to get a good ratio of omega-3 to omega-6 is eating fatty fish like salmon twice a week or taking a good omega-3 supplement. And you have to look at the ratio on the omega-3 fish oil supplement that you're taking. I just talked to somebody Friday, I think, Thursday, who she takes her fish oil, but she hates it because it tastes like fish. It's just a terrible taste. And there's plenty of supplement companies and supplements that have omega-3 fish oil that has no fishy aftertaste. So it's doable. Okay, the health benefits of the Mediterranean diet are due to the high omega-3 content in the foods of that diet, like nuts and vegetables, olive oil, and fatty fish. That's an anti-inflammatory way of eating. Okay, so I labeled this, who should be taking statins, right? So I promised I would get to that. Okay, so with everything we talked about in the last 3 classes installed, is there anyone that should take a statin? Well, first we're going to review the information on statins and for people that does not help. Okay, so we're looking at reduction in mortality from heart disease, which is one of the things statins claim to do, and they don't. So they do lower cholesterol levels, that's true. But the effect may actually increase your mortality. So statins do not increase survival in the elderly, although the PROSPER trial, PROSPER, showed a decreased heart disease mortality in this age group. However, that mortality was mitigated by an increased risk of death from cancer. So overall, on people on statins, so overall mortality was not improved in the elderly. Statins do not increase survival in women. Heart disease mortality only decreases in women who already have heart disease. So if you have heart disease, then a statin should reduce your mortality in women, specifically in women. However, there's an increased risk of death from other causes in women taking statins. So once again, overall mortality in women is unchanged as far as heart disease. There may be a reduction in cardiovascular events in women with heart disease, but in those studies, the research was insufficient to make that conclusion. Okay, statins do not increase survival in healthy people. No study has ever shown statins to be beneficial in healthy people whose only risk factor for heart disease was an elevated total cholesterol level. Okay, so the heart attack rate is modestly reduced in this population, but there's no mortality reduction. So if you want to take it and have all the other potential side effects and health problems with statins, it may reduce your risk of a heart attack, but it won't reduce your risk of death. Okay, so what do statins do? Okay, so this is evidence-based. The evidence shows that statins do appear to be beneficial in those young and middle-aged men who already have heart disease or those who are found to be at higher risk for heart disease. However, risks on that are variable. It's not uniform. Some studies showed no benefit at all. And then they're also at risk for all those horrifying side effects that we talked about with statins on Friday. Okay, statins do appear to reduce the risk of stroke in patients with high blood pressure and multiple risk factors for cardiovascular disease. Okay, they also appear to reduce the risk of further stroke in patients who have already had a stroke, especially if they have heart disease. Okay, so this is referring to an ischemic stroke, so lack of blood flow. They do not prevent hemorrhagic or bleeding strokes. Okay, so how do you stay healthy without statins? So let's say you decide, and I'm not telling anybody to go off their statin. I'm just giving you the research and you figure out what you want to do. So how do you stay healthy without taking statins? So if you go back to the article that I wrote, and the first question I had on there was, so now what? We've learned, we've heard all this stuff about cholesterol, statins, blah, blah, blah. So now what do we do? Well, how can a person reduce their risk of heart disease, heart attack, stroke, and insulin resistance? So here's the guidelines. First one's don't smoke, probably the most important thing you can do. Second is drink moderate amounts of alcohol, if you drink at all. Okay. Number 3, avoid sugar. The second most important thing you can do. If you don't get insulin resistance, you may not get heart disease. And switching from sugary drinks to diet ones actually make things worse. I see all these people, they're heavy, but they say, oh, but I drink diet drinks. Well, that's actually worse. So So to ruin all the soft drink fun that you have, a study published in September last year, 2019, showed higher all-cause mortality for people consuming just 2 sweetened soft drinks per day. Okay, that looked at 451,000 people from 10 European countries followed for 16 years and compared to individuals that only had 1 sweetened soft drink per month. There was increased risk of dying from colon cancer, development of Parkinson's disease, digestive disease, and heart disease. So sorry to put it out there, but that's a 16-year-long study that was published last fall. Okay, and again, the dietary, the diet thing is actually worse if you look at the studies on diet drinks. Okay, next, what should you do? Eat natural foods with natural fats, moderate proteins, and low carbohydrates. The idea is to aim for less than 20 grams of carbohydrates per day. So you have to read labels. Just read labels. You got to look at what you're putting in your mouth. Okay, it's amazing how many foods can push your carbohydrate intake upwards. So try to make sure any carbohydrates you eat are complex, like beans and nuts and fruit with skin, vegetables, sweet potatoes, squash, brown rice, and not simple sugar. So I used to tell people, don't eat anything that's white. So dairy products, white bread, desserts, anything with high fructose corn syrup, you should just eliminate from your diet altogether. Breakfast cereal, sweetened soft drinks, that's all simple sugars. Okay, and then eat healthy fats, don't count calories. Okay, so the following fairly healthy choices. Eat 1 avocado a day. A friend of mine eats an avocado every day and has done it for 20 years. Consume full-fat natural cheese, but not the individual wrapped American cheese, because that's not cheese. Eat cheese. Don't eat that Kraft single stuff. Well, I shouldn't pick on Kraft. There's plenty of other ones. Dark chocolate is a healthy fat. Also improves your brain function. Eat whole eggs. They have omega-3 fatty acids. The yolks have all the nutrients in them. Fatty fish like salmon, mackerel, trout, sardines, and herring, all are good omega-3 sources. And if you can't stomach seafood, take a good omega-3 or cod liver oil supplement. Okay, nuts reduce your risk of diabetes and obesity and heart disease. Chia seeds are not only good for you, they reduce inflammatory changes in your body. Extra virgin olive oil is almost universally considered the healthiest fat in any diet. Okay, incorporate intermittent fasting. This is from Dr. Jason Fung Into Your Way of Life. He's got a whole book on it called The Obesity Code. Easy to read. He basically attempts to prove that he's right. And he's, like I said, he's been looking at sugar intake and obesity and diabetes rates for, I think, 20 years. Okay, so what you're trying to do is rest your gut, similar to how your brain needs to rest while you're sleeping. So 1 meal a day to avoid triggering an insulin response during the rest of the day. That's how you get less chance of insulin resistance. Okay. The easiest way to do that is 1 meal a day in the evening, about 3 hours before bedtime. And then the rest of the day, you can drink water, you can have coffee in the morning. If you put anything in it, like even cream can trigger an insulin response. And then bone broth during the day if somebody's hungry. I've done it several times. And it's pretty easy. It takes a couple, 3 days to get used to it. So follow the guidelines above when you feast during your 1 meal a day, and don't restrict your calories or even pay attention to them. And if that becomes a lifestyle for you, you will maintain your weight. You'll lose weight and you'll maintain it. Okay, so you want to take 20 minutes to eat. It always blows my mind in high school. I'm at the high school, getting in the cafeteria line, sitting down to eat, and getting back to class. I think they have 22 minutes to do that. Well, that kind of violates the whole thing. It takes your stomach and the hormones and enzymes are released from your stomach 20 minutes to tell your brain that you're full. So if you eat until you're full, it takes 20 minutes for your brain to even know you're full. You get so that will increase your energy. I know that firsthand. If you do 1 meal a day, you're actually more energetic in the morning and throughout the day, even though all you're doing is drinking water or bone broth. Okay. So you can also do fasting for 8 hours. So if 1 meal a day is too daunting, you just eat during the intervening 6 hours. So people that do an 18-hour fast, they'll eat at noon and 6 usually. They'll skip breakfast. Okay. And if weight loss is a goal with an 18-6, so it's an 18-hour fast, 6 hours feasting, weight loss will be slower than 1 meal a day. Okay, next one is get up and move around. Even small amounts of exercise makes a difference in your health. Okay, I'm not talking about running marathons and bench pressing huge amounts of weight, although I know plenty of people do that. Hey, Crystal. I'm talking about brisk walking, 30 minutes 3 times a week. Even light biceps curls have major benefits in elderly people. Simple things like 5-pound curls. Movement of your body helps reverse insulin resistance. If you feel like you must take a pill, make it a baby aspirin. That one's controversial. It used to be that the American Heart Association said everybody over 40 should take 81 milligrams of aspirin a day. I still do it because of my blood pressure. It is hard on your stomach. It's a non-steroidal anti-inflammatory drug. It raises the risk of gastritis, really. But a British medical journal, so the British Medical Journal, looking at cost effectiveness of treatments to reduce coronary artery disease, found that an 81 milligram aspirin a day was as effective as simvastatin and 20 times more cost effective. Also cost effective was the initial treatment of blood pressure with a diuretic and a beta blocker, and more intensive high blood pressure treatment using a calcium channel blocker. The least cost effective treatments for reducing your risk of heart disease was simvastatin and Plavix, unless you had a heart attack or a stroke in the past. Okay, so that's plenty of science and stuff to mull over for the morning. I thought I was going to tell you my story, but I'm going to do it Wednesday. So we're going to talk about, I alluded to the 27 evidence-based things that you can do to maintain and stay healthy. And then I'll tell you my story about weight loss, et cetera, on Wednesday at 9:30. Okay, so that's what I got for today. I try to do it in 30 minutes, but it took me, I think, 40. But that's we've done 3 out of 4 parts. So I got one more part, and then we'll switch gears and do something else on Friday. Okay, so thanks for being here. I will see you. Have a great day. I've got to put grades in for my students by noon, so I'm going to work on that. And I will talk to you Wednesday morning at 9:30. We'll see you. Bye-bye.